I will be telling you about diabetic retinopathy. So, diabetic retinopathy is the changes that do occur in retina in diabetics. Is known as diabetic retinopathy. Okay. So, as we all know that the incidence of diabetes is increasing. So, also the diabetic retinopathy incidence has been increasing. Okay. So, and diabetic retinopathy is one of the leading causes of preventable blindness. So, as we all know that diabetes may be type 1 or type 2. Okay. So, we do get microvascular complications and macrovascular complications. So, the retinopathy is due to microvascular complications. So, what are the risk factors for diabetic retinopathy? So, duration of diabetes is very important risk factor. So, here we can see that after 30 years, almost 95% of both type 1 and type 2, they develop retinopathy. Then type of diabetes. Okay. So, diabetic retinopathy risk is higher in type 1 diabetics, and also the risk of PDR is higher in type 1 diabetics, and DME is more common in type 2 diabetics. Then the next risk factor is the poor metabolic control. Okay. So, it is the risk factor for development as well as progression of diabetic retinopathy. Then these are the other risk factors like pregnancy, hypertension, and then smoking, obesity. So, these are the other risk factors for development of retinopathy. Then coming to the pathogenesis of diabetic retinopathy. So, we do get the cellular damage, okay, and also the hematological and biochemical changes, okay. So, basically, because of increased hyperglycemia, there will be accumulation of sorbitol and also advanced glycation end products, okay. So, they lead to endothelial cell damage, loss of pericytes, and also thickening of the basement membrane. So, these are the various hematological and biochemical changes that do occur in diabetics. So, this is the flow chart showing what are all the pathological changes that do occur in microvasculature of the retina. Okay. So, basically, there is a thickening of the capillary basement membrane, and then capillary endothelial cell damage, RBC deformation and Rolox formation, and then increased stickiness of platelets and increased plasma viscosity. So, all these changes, they lead to microvascular occlusion. Okay. So, when there is a microvascular occlusion, there is retinal hypoxia, okay, or retinal ischemia. Okay. So, the retinal ischemia leads to AV shunt vessels. Okay. So, they are known as intraretinal microvascular abnormalities, and also neovascularization of the retina. Okay. So, that is due to microvascular occlusion. Okay. So, the other pathological change that do occur is the capillary leakage. Okay. So, first one is the occlusion and the other one is the leakage. Okay. So, occlusion leads to retinal hypoxia. So, that leads to the formation of intraretinal microvascular abnormalities and the new vessels. Okay. And then capillary leakage. So, we have seen that there will be loss of pericytes. Okay. So, within the endothelium of the vessels. Okay. So, this leads to the formation of microaneurysms. Okay. So, microaneurysms are nothing but the outpouchings of the capillaries. Okay. So, they are very much leaky. Okay. So, there will be leakage of the blood and then leakage of the intraretinal fluid. Okay. So, leading to retinal edema and also heartache states. Okay. So, we can see here. So, basically, there are two. So, we have seen that there is thickening of the basement membrane and endothelial cell damage, RBC changes, and the platelet stickiness increased. So, all these, they lead to microvascular occlusion. Okay. And then loss of pericytes leading to microaneurysm formation, leading to leakage. Okay. So basically there will be breakdown of inner blood retinal barrier. Okay, so that leads to leakage. Okay, and then neovascularization. So that is because of retinal hypoxia or ischemia. Okay, so when there is a retinal hypoxia, there will be release of pro-angiogenic factors. Okay, like vascular endothelial growth factor, and then platelet-derived growth factor, haptocyte growth factor, and then there will be deletion of anti-angiogenic factors. Okay, so like endostatins, angiostatins, like that. Okay, so retinal hypoxia leading to intraretinal microvascular abnormalities, which are the shunt vessels, and then the neovascularization. Okay, so unlike the normal vessels, the new vessels are very fragile. Okay, so they easily bleed. Okay, they easily bleed. Okay, and whenever there are new vessels, along with the new vessels, there will be proliferation of the fibrous tissue. Okay, so leading to fibrovascular proliferation. Okay, so this fibrovascular proliferation produces traction over the retina. Okay, leading to tractional retinal detachment. Okay, then coming to the classification of diabetic retinopathy. Okay, so according to ETDRS, okay, that is early treatment diabetic retinopathy study. Okay, early treatment diabetic retinopathy study. It has classified diabetic retinopathy into non-proliferative diabetic retinopathy, proliferative diabetic retinopathy, diabetic maculopathy, and then advanced diabetic eye disease. Okay. So before I tell the features of each and every category, I would like to tell about the anatomy of the normal retina. Okay. So you can see here that this is the fundus picture of the normal eye. Okay, normal fundus picture showing optic disc. This is the optic disc, and this is the retina. Okay, so along with the retinal vessels. Okay, and also this point around 5.5 millimeters of this area is known as macula. Okay, so at the center of the macula we get a reflex that is known as foveal reflex. Okay, so this macular area is very much essential for visual acuity. Okay, so this is the normal fundus. Okay, then in non-proliferative diabetic retinopathy, so what are all the lesions that we get? So the first one being the microaneurysms. Okay, so they are the earliest detectable lesions. Okay, they are focal dilatation of the capillary wall due to loss of pericytes. Okay, so are you able to see that small dot-like lesions, red lesions here? Okay, so that is the microaneurysm. Okay, so the small lesion is the microaneurysm, and this is the hemorrhage. Okay, retinal hemorrhage. You can see multiple microaneurysms. Okay, so they're minute reddish dot-like lesions. Okay, so on FFA they are more prominent. Okay, so are you able to see that multiple hyperfluorescent spots? Okay, so these are all the microaneurysms. Okay, so they are one of the earliest features of non-proliferative diabetic retinopathy. So what are the other features? Like retinal hemorrhages. Okay, so deep hemorrhages are the characteristic of diabetic retinopathy. Okay, so are you able to see that there are multiple, they are known as dot and blot hemorrhages. Okay, small dot and blot hemorrhages. So these are all the retinal hemorrhages. Okay, and these yellow lesions are the hard exudates. Okay, so they are like they are the lipoprotein and the lipid-filled macrophages. Okay, so these hard exudates, they can occur as clumps, or they can arrange as sursinates. Okay, so sursinates means they are arranged in a circular fashion. Are you able to see that the hard exudates are arranged in a circular fashion? Okay, this is hard exudate surcinate, and at the center we find the microaneurysm, which is responsible for the leakage. Okay, then the retinal edema, And then the venous changes that do occur in non-proliferative diabetic retinopathy are the venous looping, okay? This is the loop, and then beading, okay? And then segmentation, okay? Are you able to see that the segmentation of the blood column? So these are the venous changes. And I told you, because of retinal hypoxia, there will be IRMAs, okay? Intraretinal microvascular abnormalities, which are nothing but the AV shunt vessels, okay? They don't leak the dye on fundus fluorescein angiography. Are you able to see that, see, this is the intraretinal microvascular abnormality. This is the artery, and this is the retinal vein, okay? Between the artery and the vein, we have the shunt vessels. They are known as the IRMAs, okay? Intraretinal microvascular abnormalities, okay? Then coming to, so I told you, that non-proliferative diabetic retinopathy is again divided into mild, moderate, severe, and very severe NPDR, okay? So then coming to mild NPDR, what are the features? So we do find the few microaneurysms on the retinal hemorrhages. Are you able to see that very few microaneurysms on the retinal hemorrhages we are able to see, okay? Hard exudates may or may not be present, okay? So that is the mild NPDR, okay? Then coming to moderate NPDR, so the microaneurysms are intraretinal hemorrhages in 2 or 3 quadrants. So basically the retina is divided into 4 quadrants, okay? The supratemporal, supranasal, infranasal, and the infratemporal quadrants, okay? So microaneurysms are intraretinal hemorrhages in 2 or 3 quadrants, okay? And hard exudates and cotton wool spots may or may not be present, okay? With early mild IRMAs, okay, is the moderate NPDR, okay? Then coming to the severe and very severe NPDR, okay? So according to ETDRS, we have what is known as 4:2:1 rule, okay? So that means 4 quadrants of microaneurysms are hemorrhages, and then 2 quadrants of venous beading, and then 1 quadrant of IRMAs, okay? So if any one of the above feature is present, then it is severe NPDR, okay? Any 2 of the above features are present, then it is the very severe NPDR. So severe and very severe according to, what is that? What is the rule? What is the rule? 4:2:1 rule, okay? So according to that, the NPDR is again divided into severe and very severe NPDR, okay? So in this, are you able to see that there are multiple dot and blot hemorrhages and multiple hard exudates which are arranged in cercenates, okay? So this is a case of severe NPDR, okay? Then coming to proliferative diabetic retinopathy. So till now, I told you about the non-proliferative diabetic retinopathy, which is again classified into mild, moderate, severe, and very severe NPDR, okay? So now it is the proliferative diabetic retinopathy, okay? So which is characterized by the presence of neovascularization, okay, over the disc and elsewhere in the retina. So they are shortly called as NVD and NVE, okay? So are you able to see the abnormality over the disc, okay? So there are definitely new vessels, abnormal new vessels over the disc, okay? So, and then we are able to see the new vessels elsewhere in the retina, okay? So this is NVE and this is NVD, that is proliferative diabetic retinopathy, okay? So I told you, along with the new vessels, whenever there are new vessels, along with them, there will be proliferation of the fibrous tissue, okay? So you can see this white thing, okay? So this is all the proliferation of the fibrous tissue, okay? So this fibrous tissue, it always tries to contract, okay? So while contracting, okay, it produces traction over the retina, leading to tractional retinal detachment, okay? That means the retina will be pulled away from the retinal pigment epithelium, leading to tractional retinal detachment, okay? Then what are the types of PDR, okay? So PDR without high-risk characters and PDR with high-risk characters. So what are the high-risk characters? So we have the NVD, 1/4 to 1/3 of disc area, with or without vitreous hemorrhage or preretinal hemorrhage. And then NVD less than 1/4 disc area with vitreous hemorrhage or preretinal hemorrhage, okay? and then NVE more than half disc area with vitreous hemorrhage or preretinal hemorrhage. Okay, so this when we see this, okay, so is it with high risk characters or without high risk characters? So NVD more than 1/4 to 1/3 disc area. So definitely it's disc area means it is the one disc area is one, the size of the disc is one disc area. So definitely it's more than one disc area. Okay, so ikkada optic disc undi kada. So this is the optic disc. Okay, so the size of the optic disc is the one disc area. Okay, so it's more than one disc area. Okay, definitely it is PDR with high risk characters. Okay, and then this is the proliferative diabetic retinopathy with extensive fibrovascular proliferation, and are you able to see that there is vitreous hemorrhage? Okay, so this is all vitreous hemorrhage because the new vessels are very fragile and they bleed very easily. Okay, so this is how we get the vitreous hemorrhage. Okay, then diabetic. So till now I told you about the non-proliferative diabetic retinopathy and then proliferative diabetic retinopathy, and then the other thing is the diabetic maculopathy. Okay, so diabetic maculopathy may be diabetic macular edema, which is otherwise known as clinically significant macular edema. Okay, and then diabetic macular ischemia and diabetic macular traction. Okay, then coming to diabetic macular edema. Okay, so it is due to increased vascular permeability. I told you, no, so first one is due to microvascular occlusion leading to retinal hypoxia and the new vessels. Okay, and then now it is the increased vascular permeability leading to leakage. Okay, so leakage, because of the leakage there will be edema in the macular area. Okay, so that is known as diabetic macular edema or clinically significant macular edema. So what are the criteria to diagnose it as CSME? So there is retinal thickening within 500 microns of foveal center, and then hard exudates with retinal thickening within 500 microns of foveal center, and then edema of one disc diameter, any part of which is within one disc diameter of the foveal center. So I will show you. Okay, so I told you, no, that this is the macular area. Okay, so in this we are able to find the hard exudates, multiple hard exudates which are present within 500 microns. This is the center of the fovea. Okay, so here almost is the center of the fovea. Okay, so there are hard exudates within 500 microns from the center of fovea along with the retinal thickening. Okay, so in two-dimensional picture we don't see the retinal thickening, only in three-dimensional view. Okay, so we get the stereopsis and we can know the retinal thickening. Okay, so this is clinically significant macular edema. Okay, and then on fundus fluorescent angiography we are able to see the leak, are able to see that there is a hyperfluorescence in this area. Okay, showing that there is leak. Okay, and then what is the clinicoangiographic classification of diabetic maculopathy? Okay, so focal maculopathy, diffuse maculopathy, that means we do, so just like a heart. Okay, so angiogram is done, no, to know the vessels, is there any block in the vessels or not. Okay, so in the same manner we also do the fundus fluorescent angiography. Okay, to know the pathology in the retinal vasculature. Okay, we inject the dye and then we take the serial photographs. Okay, so depending on the fundus fluorescent angiography findings. Okay, so the diabetic maculopathy may be focal maculopathy, diffuse maculopathy, or ischemic maculopathy, and then mixed maculopathy. Okay, so we will see each one in detail. So focal maculopathy is the leak from microaneurysms. Okay, so there is a focal leak from microaneurysms. Are you able to see that there is a microaneurysm here and then here also? Okay, so there is leak surrounding the microaneurysm. Okay, so that is the focal maculopathy. Okay, due to leak from microaneurysms. And then diffuse maculopathy, where there is a diffuse leak. Okay, diffuse edema due to leak from the microaneurysms and also the dilated capillaries. Okay, so here you can see that there is a lot of retinal thickening here. Okay, with hard exudates, And on fundus fluorescein angiography, we are able to see a diffuse leak. So here all, so we can see a diffuse leak, okay, from the microaneurysms and the dilated capillaries. So this is diffuse maculopathy. So next one is the ischemic maculopathy, okay. So ischemic maculopathy is due to capillary occlusion, okay. So normally on fundus fluorescein angiography, at the center of the fovea, we have the foveal avascular zone, okay. So which is normally less than 1000 microns, okay. So, but in ischemic maculopathy, because of capillary occlusion, okay, so there will be enlargement of this foveal avascular zone, okay. Enlargement or distortion of the foveal avascular zone. Are you able to see that there is a hypofluorescent, okay, hypofluorescent area, okay. This is due to macular ischemia, okay, due to lack of blood supply, okay, due to capillary occlusion, okay. So this is ischemic maculopathy, okay. So mixed maculopathy is combined ischemic and exudative maculopathy, okay. Both ischemia as well as leak is there, then it is mixed maculopathy, okay. So diabetic macular edema maybe, so according to FFA classification, focal and then diffuse, ischemic and then mixed, okay. Then coming to OCT classification, okay. So with the help of optical coherence tomography, okay. So the diabetic macular edema is classified into, I will show you. So this is the, so in optical coherence tomography, okay, it's a non-invasive technique of scanning the macular area, okay. So just like the histological section of the retina, we get the scan, okay. So we can see all the 10 layers in the retina. Are you able to see that? See, all the 10 layers we can see with the scan. See, this is the retinal pigment epithelium and this is the ellipsoid photoreceptor layer, external limiting membrane, and then outer nuclear layer, outer plexum. So these are 10 layers we can see, okay. So here we are able to see the fluid, okay. There is a spongy thickening of the retinal edema this side. Are you able to appreciate? So there is a spongy thickening of the retina, okay. That is spongy edema, okay. And then there is a cystic edema, okay. So we are able to see the cystic collection of fluid within the retinal layers. This is cystic edema, and there is a neurosensory detachment, okay. That means there is a collection of fluid underneath the neurosensory retina, which is known as retinal detachment, okay. So in the foveal area, there is a detachment, okay. So these are the various types of diabetic macular edema according to OCT, okay. Then coming to advanced diabetic eye disease, okay. That is the fourth category. So advanced diabetic eye disease is the end result of uncontrolled PDR, okay. So there is a persistent vitreous hemorrhage. Are you able to see in this? There is a persistent vitreous hemorrhage and then extensive fibrovascular proliferation with tractional retinal detachment, and also the complication is the neovascular glaucoma, okay, neovascular glaucoma. So these are the features of advanced diabetic eye disease, okay. So this is diabetic papillopathy where the disc is involved, okay. So this is about the classification of diabetic retinopathy and different lesions that we get in diabetic retina, okay. Then coming to symptoms of diabetic retinopathy, okay. So there won't be any symptoms in most of the cases, even in stage of proliferative diabetic retinopathy, okay. So it's very important, okay. So that means even in advanced proliferative diabetic retinopathy also, there won't be any symptoms unless it is associated with macular edema, macular ischemia, vitreous hemorrhage or retinal detachment, okay. So it's very important point. That's why we should not ask the patient to wait till they get the symptoms, okay. So even before the occurrence of ocular symptoms, we need to refer the patient to ophthalmologist for dilated fundus examination, okay. So then coming to the management of diabetic retinopathy, okay. So it includes screening, investigations and treatment, okay. Then coming to the screening, okay. So what is the protocol for diabetic retinopathy screening and monitoring, okay? So in type 1 diabetes, 5 years after diagnosis, the patient should have a dilated fundus examination, okay, dilated retinal examination, okay, and then annually he should be examined, okay. And then in type 2 diabetics, immediately after diagnosis, they should have a retinal examination, okay, then annually. So according to American Academy of Ophthalmology guidelines, okay, so if the retina is normal, then annual checkups, and according to the type of diabetic retinopathy, so we advise the follow-up examinations. So what are the investigations? So blood sugar estimations like fasting and postprandial blood sugar, HbA1c, and the renal function test, and then lipid profile, and ocular investigations are like fundus fluorescein angiography and then OCT. OCT is helpful, especially in case of diabetic maculopathy. Then coming to the treatment, okay. So as we all know that the blood sugar control is very, very important, okay. So in order to prevent the occurrence as well as the progression of diabetic retinopathy, okay. So the HbA1c level should be less than 7, okay. And control of systemic factors like hypertension, dyslipidemia, anemia, and hypoproteinemia are also very important, okay. So according to categories, okay. So first one is the mild and moderate NPDR, okay. So regular follow-up is advised, okay. So we don't intervene in those cases, okay. Only when there is associated macular edema, that should be treated. Otherwise, regular follow-up is advised, okay. And then severe NPDR and early PDR, according to ETDRS study, we need to consider for pan-retinal photocoagulation, okay. So what is pan-retinal photocoagulation, okay? So this is done with the help of double frequency ag laser, okay? So we give around 2,000 to 3,000 laser burns in 2 to 4 sessions, okay? So like this manner, okay? So we leave behind the disc, the macular area, and then beyond the major vascular arcades, we do the laser burns, okay? And then, so what is the mechanism of action of these laser burns, okay? So it reduces the metabolic demand. So here, so what is the main cause for all the retinopathy changes? It is the retinal ischemia or hypoxia, okay? Is responsible for all the retinopathy changes, okay? So in this, the hypoxic retina is converted into anoxic retina, okay? Hypoxic retina is converted into anoxic retina so that the metabolic demand will be reduced, okay? What are the indications for PRP? So PDR with high-risk characters and the neovascularization of the iris. And then even in severe NPDR, actually it is indicated in proliferative diabetic retinopathy. But even in non-proliferative diabetic retinopathy, there are some circumstances where we do advise PRP, okay? So that is poor compliance for follow-up, and then patients with nephropathy, pregnancy, and one-eyed patients are also should be posted for PRP, okay? Pan-retinal photocoagulation, okay? Then coming to the surgical treatment, okay? So the surgical treatment is indicated for proliferative diabetic retinopathy when there is a dense vitreous hemorrhage, okay? So we do the pars plana vitrectomy, okay? So that means we remove the vitreous, okay, along with the hemorrhage, okay? And then we do the endolaser, okay? So, and then for advanced PDR with tractional retinal detachment and our combined retinal detachment, we do pars plana vitrectomy plus membrane peeling. Because what is the cause for tractional retinal detachment? It is the fibrovascular membranes. Okay, so the fibrous tissue along with the new vessels. Okay, so they are responsible for traction over the retina, leading to tractional retinal detachment. Okay, so we do remove all the membranes which are producing traction, which are responsible for tractional retinal detachment. Okay, and then we do the laser. Okay, endolaser. Okay, so if the retina is detached, we need to reattach the retina. Okay, by scleral buckling. Okay, scleral buckling, and then internal tamponade with silicone oil or gases like SF6 or C3F8. Okay, so if the retina is detached, so retinal reattachment is done by internal tamponade or external tamponade. Okay, so internal tamponade means we push the retina towards the retinal pigment epithelium. Okay, and that is internal tamponade. So that is done with the help of silicone oil or gases like SF6 or C3F8. Okay, so external tamponade means we push the sclera towards the retina. Okay, so that is the external tamponade that is done with the help of scleral buckling. Okay, so here you can see that this is the pars plana vitrectomy. Okay, so this is how we introduce the vitrectomy ports. Okay, ports, and then we introduce the light source and then the vitreous cutter. Okay, and then infusion. Okay, so we remove the vitreous. Okay, along with the hemorrhage if there is hemorrhage. Okay, so and then we do the membrane peeling. Okay, so we remove the membranes which are producing the traction. Okay, which are responsible for tractional retinal detachment, and then we reattach the retina. Okay, so management of macular edema. Okay, so the macular edema, we have seen that clinically significant macular edema. So it may be focal, diffuse, okay, or macular ischemia, or mixed. Okay, so here according to OCT, okay, so optical coherence tomography. So according to OCT, the macular edema may be center involving or non-center involving. Are you able to see that? See, here the center is not involved. Okay, so it is away from the center. So we need to classify it as center involving or non-center involving. Okay, so if it is non-center involving edema, so we need to look for whether it is a focal leak or the diffuse leak. Okay, so if it is a focal leak, we do the focal photocoagulation. Okay, that means we directly treat the microaneurysm which is responsible for the leak. Okay, are you able to see here that the microaneurysm is treated? Okay, focal photocoagulation. Okay, so this is the for diffuse macular edema. We have seen now the diffuse macular edema, we do the grid photocoagulation. Okay, grid photocoagulation. So laser burns, low intensity laser burns. Okay, in a grid fashion is done. Okay, so this is the focal or grid laser if it is a non-center involving macular edema. Okay, so if it is a center involving macular edema, definitely anti-VEGFs. Okay, so even for the macular edema, it is the retinal hypoxia is one of the cause. Okay, retinal ischemia, okay, is also the cause for leak. Okay, so that is why we do give what is known as anti-VEGF drugs. Okay, so we have seen now whenever there is retinal hypoxia, there is release of the vascular endothelial growth factor. So we give the anti-VEGF drugs. Okay, or if there is no response with the anti-VEGF drugs, we need to give the intravitreal steroids. Okay, so intravitreal anti-VEGF drugs, they are indicated in diffuse diabetic macular edema, which is center involved. Okay, center involved diabetic macular edema, and also diabetic macular edema with neurosensory detachment, and then PDR, proliferative diabetic retinopathy with persistent new vessels even after panretinal photocoagulation. So even after doing panretinal photocoagulation, if there are persistent new vessels, okay, so in those cases also we need to give anti-VEGF drugs. Okay, and also prior to retinal surgery, we do give intravitreal anti-VEGF drugs in order to reduce the activity of the new vessels. Okay. So according to diabetic retinopathy clinical research network is there. Okay. So drci.net. Okay. So the different protocols. Okay. So according to protocol I, we need to treat the center involving DME with intravitreal anti-VEGF agents. Okay. Till the macula is relatively dry, followed by focal laser. Okay. So what are the various anti-VEGF drugs? Okay. So ranibizumab. Okay. Ranibizumab, and then bevacizumab, and then aflibercept. Okay. Ranibizumab, bevacizumab, and aflibercept. Okay. These are the anti-VEGF drugs. So we give them intravitreal injections. Okay. And then intravitreal steroids. Okay. So patients with diabetic macular edema who are not responding to anti-VEGFs. Okay. Then we need to go for intravitreal steroids. Okay. So we have different steroids like intravitreal triamcinolone. So with this, there is steroid-induced glaucoma and cataract are the complications. Okay. So now we have intravitreal dexamethasone implant. Okay. So that is Ojidix implant. Okay. You can see that the implant is injected into the vitreous cavity. Are you able to see that? This is in the vitreous cavity, the implant. So it slowly releases the drug. Okay. And it will act for 3 to 6 months. Okay. So you can see that before implant, this is the edema. After implant, see how much reduction of edema. Okay. So that is about the diabetic retinopathy. Okay. So what is the, so in a nutshell, so the diabetic retinopathy is classified into four types. What are they? First one is the non-proliferative diabetic retinopathy, and then proliferative diabetic retinopathy, and then diabetic maculopathy, and then advanced diabetic eye disease. Okay. So again, non-proliferative diabetic retinopathy, what are the types? Mild, moderate, severe, very severe. Proliferative diabetic retinopathy with high-risk characters and without high-risk characters. Okay. And then diabetic maculopathy, we have seen diabetic macular edema, diabetic macular ischemia, and then diabetic macular traction. Okay. And then diabetic macular edema, again, what are the types? So, what are the types? Depending on FFA. What are the types? Focal, diffuse, and then ischemic maculopathy, and then mixed maculopathy. Okay. So that is the, on FFA. Okay. And then on OCT, we have seen spongy macular edema, and then cystic macular edema, and then with neurosensory detachment. Okay. So, and also we have other different types. Okay. So that is according to OCT. Okay. Then we have the advanced diabetic eye disease. Okay. And also regarding the treatment also we have seen. Okay. So for the mild and moderate NPDR, follow-up. Okay. So regular follow-up should be done according to the protocol. Okay. And then for severe, very severe, and then proliferative diabetic retinopathy. Okay. So we need to treat with laser. Okay. That is pan-retinal photocoagulation. Okay. Pan-retinal photocoagulation. Okay. And then for diabetic macular edema, so whether it is center involved or non-center involved. So if it is non-center involving edema, we need to do focal or grid photocoagulation. Okay. So if it is center involved macular edema, definitely anti-VEGF drugs or intravitreal steroids. Okay, intravitreal anti-VEGF drugs or intravitreal steroids. Okay, so and also in advanced PDR. Okay, in advanced PDR, definitely surgery. Okay, surgery also we have seen pars plana vitrectomy. If there is a non-resolving vitreous hemorrhage, definitely vitrectomy, and then endolaser photocoagulation should be done. Okay, so if there is a tractional retinal detachment, pars plana vitrectomy, and then all the membranes which are responsible for traction should be removed. Okay, and then endolaser. Okay, so at the end, the take-home message is that all the diabetics should have a dilated fundus examination. Okay, so we have seen that if they are type 1 diabetics, 5 years after diagnosis, and then every yearly once checkup. Okay, so if it is type 2 diabetics, so immediately after diagnosis, they should have a dilated fundus examination. Okay, and then annually. Okay, so it's not after the development of symptoms, visual symptoms. Okay, so even prior to the occurrence of visual symptoms, the patient should be referred to ophthalmologist. Each and every diabetic patient should have a thorough eye checkup in order to prevent the blindness. Okay, so in case of advanced diabetic eye disease, definitely there will be irreparable loss of vision. Okay, so it cannot be repaired. Okay, so in order to prevent the blindness, so definitely we have an important role. Okay, so you need to refer all the diabetics, maybe your family members or your relatives. Okay, so for a dilated fundus examination in order to prevent the blindness due to diabetic retinopathy. Okay, thank you.